The gut is the second organ that's most commonly affected. And again, the causes are multifactorial. These patients have portal hypertension. The gut becomes edematous. There is bacterial overload, overgrowth. There's bacterial translocation, and patients might not be able to actually eat well enough for their metabolic needs. And most of these patients will need some form of supplementary of nutritional supplements, whether it's in the form of tube feeding. And when the gut is really not able to manage the nutrient requirements, then they might need partial or even total parenteral nutrition until the gut is stabilized. We have seen that there is an increased incidence of neurological problems in these patients. And when I say neurology, I don't really mean a frank CVA, but more like confusion, drowsiness, seizures, altered behavior. And again, it's multifactorial. It can be related to some amount of encephalopathy, could be medication related, such as tacrolimus, could be related to the sepsis, the ICU encephalopathy. So all of these things need to be carefully assessed and treated. And we have found that in some instances, changing tacrolimus to cyclosporin has helped in patients who develop altered sensorium or who develop neurological symptoms. The other main question that everybody asks, that we ask almost every day when these patients are there on the ward or on the ICU, is that the patient is doing reasonably well. Suddenly, you find that the enzymes have gone up. We're not sure, is it sepsis or rejection? And this is a very common dilemma. And biopsy is almost always non-specific and non-helpful. It'll always show sick hepatocytes, some inflammatory cell infiltrates. There'll be some cholestasis. There might be mild rejection. And it's very difficult because the treatment for the two is diametrically opposite. And you don't really want to treat one while missing the other. And the key again here is just due diligence. You need to look at the patient carefully, assess, look at the charts, look at the trend of blood tests, and then decide what we want to do. And more often than not, we are on the side of treating sepsis than on the side of rejection, simply because rejection in such sick patients is not very severe. That's probably one thing we believe in. And the second issue is it's probably better to delay treating a mild rejection for a day or two rather than delay treating sepsis for a day or two. So I think clinical judgment, and this is something that we need to discuss as a team, the ICU team, the surgeons, hepatologists, everybody has to discuss these patients carefully, look through all the charts, and then come to a decision as to what to do at any particular point for this patient. So these patients do need a lot of work on a day-to-day basis to get them through this period and get them home. Pharmacological methods of reducing portal flow, vasoactive medications such as terlipressin and octreotide are being used. They are very effective very early on in the post-transplant period. And there is additional data to say that somatostatin and its analogs such as octreotide, they actually have multiple effects on the regenerating graft. So they actually improve hepatic microcirculation. They cause splanchnic vasoconstriction, so they decrease the amount of portal blood flow into the liver, and does help increase arterial blood flow. And they have also been shown to actually slow down regeneration. And we talked about earlier in the talk that rapid regeneration is actually a big problem in small size grafts. And by slowing down regeneration, they ensure that regeneration is more orderly, that the hepatocyte component and the non-hepatocyte component of the liver, both of them regenerate in a more orderly fashion. So the amount of hepatocyte injury and liver dysfunction is reduced. So I think there is an increasing role for octreotide, and we need more clinical studies to confirm its role. Beta blockers and diuretics are required probably a bit later in the clinical course, mainly to deal with the increased ascites in these patients while they're having early allograft dysfunction. there are case reports of splenic artery embolization being used after 1 week, 2 weeks to reduce portal flow and treat early allograft dysfunction. I mean, in theory, it does work. Splenic blood forms a large component of portal flow, and by reducing it, you can reduce portal flow. But personally, I'm not really sure how effective it is. And you should always remember that there's always a publication bias. It's likely that for every case that's reported with successful embolization, there might be a few cases where it didn't work and nobody's bothered to report them. So yeah, this is something that we can consider as an option, but there's no clear evidence as to its benefit. Liver support devices. There are a lot of liver support devices available in the market. You have the artificial, bioartificial. I think in terms of early allograft dysfunction, the most commonly studied technique has been plasma exchange. There was an earlier study in 2016 from Asan, which looked at total plasma exchange TPE in patients with early allograft dysfunction, and they showed good outcomes, better survival in the TPE group as compared to the non-TPE group. We looked at our data last year in patients who had and who did not have therapeutic plasma exchange for early allograft dysfunction after LDLT. Obviously, this was an uncontrolled study, and the patients who underwent TPE were sicker, but still there was no survival benefit, and we actually found higher infective complications in the TPE group. So TPE is something that we still do use on a very selective case-to-case basis, mainly in patients who have persistent cholestasis and renal dysfunction, but without too much of an inflammatory pattern in their clinical behavior. I think we have a full session on retransplantation early allograft dysfunction, so I won't spend too much time on this. But I think the two things in the LDLT setting, one is timing. We need to identify the time point at which we know that this liver is not going to work. But before the patient becomes so sick that we can't do a transplant. And the second, obviously in India, definitely is the logistics. A patient who's had a LDLT, the ability to actually find an alternative suitable donor and the financial issues associated with the retransplantation are very difficult in our setting. So it's not something that we can actually talk easily of retransplantation in the LDLT setting. In terms of actually identifying patients, there's been a lot of data in the DDLT setup, which looks at multiple factors to see when the patient needs a retransplant. Something similar is not being developed in the LDLT setting. There are a few single center studies. I think the one in fact, the study that we discussed from Delhi by Dr. Ramesh, that can actually be considered as a study which is more useful for identifying patients who will not make it without a retransplant, because using their criteria, the chance of death in patients who satisfy the criteria was 90%. So if a patient actually fits those criteria, then we should probably seriously think of retransplantation. I mean, this is just my view. So we need much more data on the LDLT setting to identify patients who are unlikely to improve with standard medical therapy and who are well enough to benefit from the retransplantation. But I hope we can discuss that in the panel discussion towards the end of this meeting. I'll finish here. Thank you very much. I'll hand over to you, Prajni and Selva.
Thank you very much, Dr. Srini. That's an excellent talk. You gave thoroughly explained about pathophysiology and how to manage a very difficult issue. And before going to questions, I'm just we are delighted to welcome Professor Heaton. He just joined the group. And Professor, please switch on the video, Prof. And if he has any questions, Dr. Weil or Jason. Prof.
Thank you. I managed to catch most of the talk, I think, and I'm pleased we're not going to overlap too much in that. And I apologize to anyone who comes in late thinking they're going to hear Dr. Eddy talking and have to put up with me.
No.
But I think there are a lot of questions that come out from that talk that I think we can maybe speak to at the end of the talk, Raj.
Yes, Prof. After the case presentation, maybe we can address those issues.
Yeah.